I think everything we do has to be patient-focused and patient-centered. I think in the past we've paid a lot of attention to how we treat the medical staff and making things comfortable for the medical staff, providing an educational setting for training physicians of the future, medical students as well. And the focus has not really been on the patient. And I think, you think about it for a second. I mean, you come into the hospital at a time when you're most vulnerable and you get put in a semi-private room with a stranger. Can you imagine checking into a hotel when they say, here's who your roommate will be? Can you just imagine? I mean, and oh, by the way, you'll be sharing a bathroom, and we've got a curtain between you, so don't, it's not, their family may come in to visit them as well, and they may make a lot of noise, but it's not to worry. That's how we do things here. It's a hospital. So, and that's when you're well and feeling fine, but can you imagine when you're sick and not feeling so well, and then you've got to deal with that situation. So there really wasn't sort of a lack of regard for patients. I mean, hospital gowns open in the back. I mean, small things, just the gowns, how patients are transported, waiting. Is it reasonable to have somebody sit down in radiology for 2 hours waiting for a procedure when they could be in their, in the bed upstairs, coming in for an operation, telling you to be here at 6 in the morning and not getting to you till 2 in the afternoon? We've not done a very good job of respecting, number one, people's dignity, but also respecting their time. And, just some simple things like having some respect for people's dignity and their time are the very basics of, of customer service. I don't think there's any question that medical care is going to be moving closer to the home, and in fact moving into the home. The hospital no longer really is the center of the universe, and much of what we do is done as an outpatient. And the logical extension of that is, what can we do in the home? And especially with the use of technology, I think we will be able to do more and more in the home. So we need to be nimble enough to recognize that inpatient business is not going to be the be-all and end-all of what we do, and we need to be looking at some alternatives. And for that, we've put the Temple T out in the community, and we'll continue to do so, both from the urgent care standpoint as well as additional outpatient settings. And that's a part of our overall strategy, is to be much more out in the community. And places where we've gone, we've been very successful even in the short run. We are trying to look far enough ahead to be able to predict where the disruptions might occur and where there might be major disruptions. We've modeled every scenario that I've just mentioned to you. We've modeled what the decrease in disproportionate share would look like. We've modeled what some of the decreased reimbursement would look like. We've modeled what it would look like with a decrease in the indirect medical education subsidy, what it would look like to the hospital. We've modeled what it would look like if some of our Commonwealth support decreased as well. So we've looked at what it would mean to the organization if we did have to sustain those kinds of losses. So I think by at least taking a look as far into the future as we can and trying to make the best predictions that we can will allow us to be fairly nimble. And I think we have to be bigger. I think there are several other systems in town that it would make a lot of sense for us to partner with, and whether that's some sort of joint operating agreement or an actual full asset merger, I don't know. Somewhere along that spectrum, we need to be nimble enough to foster some of those relationships. But the overarching goal and the overarching vision really is to expand the size of the system and to be a must-have. I think we need to be much more transparent about quality metrics. Are we meeting the various metrics that we need to be meeting, and some of them are pretty simple, but others, you know, are fairly major. We're going to be looking, and certainly the federal government's going to be looking much more closely at outcomes, at morbidity and mortality. In terms of the patient sharing in the cost or knowing the cost, you know, there are very few other things in society where some third party is paying and you as the consumer really don't have to be concerned because, quote, someone else is paying. There's no question in my mind that if patients see what some of these costs are, what the charges are, that people will be much more selective as to how they make a decision. And for that matter, if some of that cost is put onto them, they'll be very selective and discriminating as to what they choose to do.